All right. Okay, so I'm going to combine my welcome with my presentation. So I just need one of my tech people to tell me how do I advance this. Is this how we do it? Okay, so welcome to the 3rd Annual Health Disparities Conference at Teachers College. And I'm going to be addressing the conference theme, Toward Global Health Transformation, Research, Demonstration Projects, and Model Interventions for, I just lost it on the screen. No, we need the tech people already. Just touch the screen? Thank you. And model interventions to reduce disparities in health. And as you can see, I'm also the conference director and professor of health education. We're really going to save time today by not doing formal introductions of our speakers. So you can see our keynote speakers and featured speakers and the way in which we have their biographies in the conference program. And then, of course, we ask you to do what most of the world is doing, and that is to Google the names of our various featured and keynote and other panelists and workshop leaders, and indeed to find out all the details there are and all the links to their journal articles and publications. So, in terms of my welcome, I would just like to say that part of what we intend to do at this conference today and tomorrow is to really describe regional, national, and global work. We're going to focus on research, on closing gaps in education, as well as closing gaps in health, as well as closing gaps in capacity. So that some of the talks are going to talk about the way in which we need to do capacity building for research, community empowerment, so that communities can self-determine their own health. And so you'll see researchers talking about how they are building capacity by training researchers in places such as Central Asia, as well as training peer educators. And so there also are demonstration projects, some of which overlap with that research. And so we'll have speakers talking about their work in New York City, powerful demonstration projects across the United States, as well as globally in places such as India, the Virgin Islands, Africa, Central Asia, etc. So you can peruse the program to get a full picture of that which I speak. And so also there are in your conference program little symbols. So there is a toolbox that is aside various activities alerting to you to the first point here, which is that in many sessions our goal is to provide tools for your use in your work, so that you end up having something akin to a newly equipped toolbox. We have a heart symbol for those sessions dealing with special populations of the kind you see listed. And we also have community members who will be celebrating Women's History Month. We ask all of you to support the health of women and encourage them to access health care and free screenings at our community health fair. So you will see a symbol, the female symbol sign, next to those sessions. And for example, we're also going to be having an internet table at the community health fair where you can actually take a survey. We have expanded the divahealth.org survey, which debuted at this time last year. It's now been expanded to have a Haitian station, where we have over 6 videos in Creole with role plays, as well as another 19 that are educational, translated into Creole. We have a beauty shop station urging beauty shop owners to transform their beauty shops into places where there are internet access facilities so that they can feature the divahealth.org website, as well as a capacity building station, which is going to be launched for tomorrow as well. And in this capacity building station, individuals can actually take the training that's been codified in a book on sale back there, which is HIV/AIDS prevention peer education training. And this capacity building exercise allows them to go through the book online, and within a couple of months we're going to be able to issue a test that they can take and certificates. So we're attempting to foster international internet-based training of peer educators to build capacity. And then we have the AIDS ribbon, acknowledging sessions devoted to HIV/AIDS. And again, at our health fair, even if it's raining and the wind is blowing, we're going to have the street lined with vans. Imagine 3 rapid testing facilities that are going to be available in comfortable vans, as well as mammograms. We have U.S. Doctors for Africa. That is a symbol for sessions We have some guests coming who are working on developing a regional initiative, as well as psychosocial interventions for those who are devoted to going to Africa, and expanding the initiatives of doctors who are going to operate mobile clinic vans in Africa to basically meet the needs for medical care in Africa. So that symbol, USDFA, signifies those sessions. And then we have youth. We have a Health Disparities Academy. Many of those youth are in school now, or college, taking their college courses. And so many will show up at various points later today or tomorrow. So the idea is that we're committed to fostering a pipeline. And therefore, we're having a hip-hop panel and a cultural show that's going to occur during our reception. They're going to have a hip-hop panel from 4 to 5:30, 3:45 to 5, whatever those times are. Please forgive me. It's in your little program. And then we're going to have the cultural show, which is from 5 to 6:30 at our reception. So that is an accurate figure. Okay, so our conference symbol. What are we all about? We're really about moving from inequity in health to equity in health. And this is a symbol that basically represents the research group on disparities in health. We're also using this symbol to remind all of you that part of what we're doing is launching a new field of equity in health, and we're fostering a 21st century global civil rights movement for equity in health for all. So, part of what we're doing today is we're putting out a conference call for a new global civil rights movement for equity in health and educational access for all. And so I'm going to talk now about the forces driving and embodied within a new field of equity in health. So, what is this? It's a commercial, but it's also the source for the information that I'm going to be talking about today. And so we're very grateful to Springer Publications that they're offering a one-time discount of $49.95 for this book, Toward Equity in Health, A New Global Approach to Health Disparities. And there are 31 chapters in this particular edited volume. These are the proceedings of the first annual Health Disparities Conference in 2006. And there are at least a dozen people in this room who have chapters or have contributed as co-authors to chapters in this edited volume. So this is the time to get the copies for your mother, okay? Okay, so now let's talk about the very first chapter, which is the introduction, Forces Driving a Global Civil Rights Movement for Health. And I'm absolutely delighted that Sherry Sussman is here, representing Springer Publications. So let's give her a hand and thank her for that discount today. And thank her for the contract for that book in 2006. And who knows, maybe we'll get a contract for yet another volume to come out of this conference today. So be very nice to Ms. Sussman. I fell in love with her when she read chapter 1 and called it a tour de force. So let's see if you like it too. Okay, so in terms of what we are talking about, in terms of launching this new field of equity in health and the driving forces, as an introduction, let's consider what we're really talking about. We're talking about something as basic as fundamental human values, the value of engaging in fair play, of acting with impartiality, of allowing a sense of social justice to guide us so that we can ensure that all human beings are free to enjoy the right to health, as well as the pursuit of their physical, emotional, mental, and spiritual well-being. And of course, diverse groups are going to define that and elect to pursue it as they may. In addition, we can turn to the work of many others, for example, that of Braveman, so that what I'm talking about in this chapter is really validated by a host of researchers and scholars. So I turn to them in making the case for that which I speak in this particular chapter. And so Braveman does a wonderful job in noting that pursuing health equity, in other words, striving to eliminate health disparities, and note that what we are really about is shifting the discourse, that we're very much talking about what we want as opposed to what we do not want. We do not want more health disparities, hence we're shifting the discourse or seeking to the United States by talking about the pursuit of health equity. And so we're talking about striving to eliminate those disparities strongly associated with social disadvantage. And so it can be thought of as striving for equal opportunities for all social groups to be as healthy as possible. In addition, there can be a selective focus. In other words, we are totally justified in taking a selective focus on improving conditions for those groups who have had fewer opportunities, removing obstacles for those who have been poor, disadvantaged, persons who are not heterosexual, those who've been historically facing various obstacles to their rights to health and other human rights. So this is Braveman talking here. Addition, come on, little button. We don't have time for you to not want to turn. Okay, and then we're talking about a global movement from an equity in health to equity in health. And so we can turn to the work of Washington, who in her book, Medical Apartheid, cites Donna Christensen, who basically said health disparities are the civil rights issue of the 21st century. And also Washington began her book by citing Martin Luther King Jr., who said of all the forms of inequality, injustice in health is the most shocking and the most inhumane. And so we can also now justify why are we talking about a global approach? Because we now live in a community that is indeed global, that we travel, and what we observe through broadcast images using technology can serve to alert us as to what's going on in any part of the world. We could, if we chose to, rapidly mobilize and take action to quickly respond to literally any health issue or crisis in literally any region of the globe, dispersing resources. However, we can also see some evidence of a differential interpretation that can occur with regard to what is broadcast, the images that we see. And so we see two examples, one in which we indeed respond to images of the Asian tsunami, and we did mobilize resources. However, there was a lot more difficulty doing so when we had Hurricane Katrina. And so part of what we need to appreciate is that some of these differences involve the extent to which there is a need for a global health transformation. Again, think of those values, fair play, for example. And so we need to value and pursue equity in health for all as a global interdependent community with vast resources at our disposal. And again, can we act with impartiality? Can we allow a sense of social justice to guide us? So what is our work? What is our role? What is the role of this conference? The idea is that in 2006, if you were here, you may recall that we declared a decade of health disparity reduction. And so we talked about types of evidence, how we need to go beyond the gold standard, randomized clinical trial, and also begin to engage in community collaborations, partnerships, and of course, community-based participatory research. And so today we are going to declare a 21st century global civil rights movement for equity and health for all. And so what are the forces? Before I ask you to join in such a call, perhaps you deserve a rationale. And so this is where we can seek yet other evidence and focus on the 13 forces that are driving this. And we're also going to talk for a moment about the mechanism for sustaining this movement and promoting a new field of equity and health. And so we have the Journal of Equity and Health with a slide where something jumped around. See, this is why you need a PDF. But in any event, as you can see, the inaugural issue is February 2008. So this is also going to be online and available tomorrow at the Community Health Fair. That's the goal, at least. But I have my webmaster working on about 5 projects. So we'll see how he does and if indeed that occurs by tomorrow at the health fair. And so what are these guiding principles, these driving forces? There's a drive for a new major paradigm shift, a drive for new models of healthcare and training, the drive for new theories, perspectives, and identities, the drive for evidence-based approaches, the drive for transdisciplinary teams and community-based participatory research, the drive for globalization and global collaboration, the drive for cultural competence and cultural appropriateness, the drive for health literacy and linguistic appropriateness, the drive to ensure the right to health, the drive for social justice and acknowledgement of forces in the social context, the drive to protect and support the most vulnerable, the drive to repair damage, restore trust, and take responsibility, and 13, to redistribute wealth and access to opportunity. And so let's review each of these, spending a little bit more or less time on each one. But since I'm obsessed with the first one, it'll have a little bit more attention. The drive for a major paradigm shift. And so you also see the A over B that is a part of the research group symbol that's on your conference program. And so what does that symbolize? It symbolizes the extent to which we need to stop that which does not work anymore, the paradigmatic behavior and ways of being associated with hierarchical domination. And so A over B, any actor A above, any actor B put in the position below. And so that is a symbol of many relationships of hierarchical domination. More specifically, given any actor A and any actor B, the goal is to really conceptualize the whole dynamic of hierarchical authority and the way in which it can foster oppression. So, you know, some examples: A, master; B, slave; A, heterosexual; B, sexual diversity. And of course, the way of teaching that we're trying to move away from: A, teacher lecturing all the time; and in position B, student passive recipient of knowledge. And so what do we want? We want to move to A equals B. And so we need to realize that that is really a symbol of non-hierarchical equality. That's what we're talking about. And when we get to A equals B. So we're trying to stop A over B and move to the new paradigm. And so what do we need to do individually? We all need a heightened state of awareness. In other words, can we catch ourselves in the act, so to speak? To what extent can we engage in self-observation, or as the behaviorists would say, self-monitoring? Can we stop any behavior? And so in this case, it would be those ways of thinking, behaving, and being in the world associated with A over B. Can we potentially stop, and not only stop, but then go on to observe even ourselves or organizations as we engage in those old ways of thinking and behaving? And then after we stop, can we actually create a clearing or a space for the emergence of something new? Can we consciously direct ourselves to execute new ways of thinking, behaving, and being? And since Professor Greer is here, might we even get some positive reinforcement for doing so? And might we systematically rehearse and refine over time new ways of thinking, behaving, and being, so they become automatic, natural responses from which we also get a sense of natural reinforcement and gratification. In other words, if we engaged in fair play, it just might feel good. All of us living in the aftermath of centuries of domination and oppression, we have been socially conditioned in places such as the United States, but we can bring about a new paradigm of A equals B, relationships of equality, freedom, justice, and all the conditions for all reaching their full human potential prevailing. And so the goal of interpersonal relationships reflects this non-hierarchical state of equality, or A equals B, thanking and acknowledging the work of Taylor. And this non-hierarchical state of equality can be a desired status and, in fact, come to characterize all interpersonal and human interaction globally. So now, the drive for new models of healthcare and training. So we're talking about a shift here to a new paradigm that includes new models of healthcare, new ways of training, the overall healthcare system, medical field. Might we, in terms of our public health systems, also shift? And might we challenge the current hegemony in some of these models? And also, could we even begin to value things such as prevention? So these are things that many of you in the audience are ever so familiar with. And then third, a drive for new theories, perspectives, and identities. And so the new paradigm necessarily requires new theories and new perspectives. Part of what we're moving toward is literally a menu of evidence-based approaches, a menu of integrated theories and approaches from which we could choose and select and tailor interventions to meet the needs of various diverse groups, even as their needs may change at various times. We need to avoid engaging in blame the victim or deficit-oriented research, where we conduct the kind of research where we end up comparing, let's say, blacks versus whites or whites versus Hispanics, et cetera, and those who tend to be in position A tend to look a lot worse at a lot of those variables, and we have in effect mostly identified variables internal to the person. So even though we did not intend to, we may be contributing to blame the victim research. More evidence of deficits belonging to those in position B historically, who are our most vulnerable population groups. And so could we avoid locating such key variables within the individual? And so it's really important that we begin to focus on the role of the social context. So what are those social context factors that go along with A over B, such as the hierarchical domination, the forces of oppression, and of course, the good old socioeconomic status differences that result. And so how can we begin to really focus on strengths, assets, as well as view many problem behaviors as merely attempts to cope and adapt in a stressful social context? And then we can begin to talk about adaptive versus maladaptive coping. We can identify adaptive ways of coping affectively, behaviorally, and cognitively, and create interventions and disseminate those kind of interventions so that others might replace maladaptive coping with adaptive coping. Our identities as researchers, how many of us in the process of reading all those journal articles, all of those books, end up essentially being socially conditioned into having an identity as a professional that's very tied up with our theory. But what if that theory doesn't apply in another part of the world or with a particular population or group? And so to what extent do we need to actually talk about a transformation of the identity? Indeed, to work with communities around the globe, we have to assume responsibility for deconstructing an identity that can be rooted in our Western theories, and for reconstituting and rearranging our own identities. The goal is to create an identity so that we can perceive that which is of value in a social, cultural context that may be new to us, and to actively seek to enter that context through a gate that's appropriate. Erhai Ngua talks about, can you go to Africa, for example, and enter through a gate that comes from our Western theories when we're entering a brand new cultural context? And so there's also a drive for evidence-based approaches. So it's crucial to move toward a menu of evidence-based approaches. So to the extent that in 2006, we declared a decade of health disparity reduction research, the goal is that we're going to be able to generate a menu of evidence-based approaches for each challenge that we face. And of course, this is the evidence-based approach that's standard in most fields. The goal is to generate this evidence-based approach decade by decade, and eventually we can certainly embrace the goal of eliminating these disparities. And then there's a drive for transdisciplinary teams and community-based participatory research. And so imagine that we need to conduct research from multiple perspectives that are brought to the table when we truly have representatives of different disciplines there, as well as stakeholders, community members at the table. Part of the reason that this conference is structured in the manner in which it is because we have a last name, Columbia University. And sometimes people might, if we did a little free association test right now, some of you might think eminent domain, record shop closing in Harlem. So the idea is that to the extent that we have that last name, we're having this community health fair to very much repair and heal relations, because we need community partners. We need to partner with community-based organizations, with our clinics, our hospitals, our nonprofit organizations, our churches, because they are the members of the community groups that we need at the table as key stakeholders. So we are partnering with them here within this conference and opening up, for example, the Saturday 4 to 5:30 session to any community member who'd like to come to any of those sessions. So in this way, we need to appreciate that professionals and community members have to enjoy mutual respect and recognition, as well as a free-flowing dialogue among equals. Those are key aspects of the new paradigm. And so we need also to have community members involved from the very beginning of the process, from conceptualization of research. So for example, we have Nabila El-Basil of the School of Social Work and her colleagues who are going to be presenting tomorrow. Her colleagues will be representing her, but they have done excellent evidence-based research, come up with models that have been embraced for dissemination nationally and globally, and they can describe involving community members from the very beginning, conceptualization, implementation, dissemination. The goal is to avoid critical errors where we may misrepresent the reality of the groups of people with whom we work. The drive for globalization and global collaboration. The internet and new technology certainly make us a global community. And so if we are bound together by forces of globalization, and we have things such as a world economy, politics, culture, human affairs, there's probably more excitement and more conversation in some parts of the world about our current election campaign because we are a global community and images are being broadcast around the world, not only of disasters, but also of our everyday human affairs. But we need a new definition of globalization. And so this is where I actually take from a book that Nana Krantam Ayabwafo has put out. And so she was the female master drummer who performed with her African drummers. But in the back of the book, in back of the room, there's a book called Tigray Speaks, where basically what I take from there is the concept that what affects one affects all. So in that particular book, Tigray Speaks, Ayabwafo 2005 is talking about values, African healing wisdom, values that can direct us. And so to what extent do we possess a consciousness that what affects one affects all? And we can think of multiple examples. We may not care about what another country is doing or another state is doing until we have acid rain going from New Jersey to Canada. We might not care about global warming until, of course, we find that we are more vulnerable to a hurricane or a tornado or to a disaster. So the idea is that what affects one affects all. And it's a consciousness of our fundamental interdependence as a global community, as well as the resulting process of learning to work collaboratively and to share and disperse resources within our global community to ensure social justice, equity, the protection of human rights, and the sustainability of the planet. None of this makes very much sense if we don't have a planet that is not well. And so this is something that's offered as we think about the drive for globalization and how we might cognitively reframe globalization. The drive for cultural competence and cultural appropriateness. There's a drive for cultural competence and cultural appropriateness. This is something that has driven here at Teachers College, our very own multicultural counseling focus in the Department of Counseling and Clinical Psychology. We have some of the very best experts in the world here, from Daryl Bing-Su to Madonna Constantine to Robert Carter. And so the idea is that to what extent do we not have to reinvent the wheel? There is tremendous scholarship in terms of how to train counseling psychologists to be multiculturally competent. We can draw upon this in ensuring that our physicians, our nurses, our health educators, that all who are going to work in this movement to bring about equity and health for all, that all of them possess cultural competence and are going to engage in demonstration projects and research that is culturally appropriate. We cannot just take a grant funded in 2002 that we implemented in the Bronx, dust it off and send it off and say, we're now going to do this in 20 places in Africa with absolutely no modifications. Okay? So it becomes absurd, but might get you funded. Probably has gotten some people funded. But the idea is, to what extent do we need to really think about cultural appropriateness? Do we have the representatives, the stakeholders at the table from the very beginning, and we discuss and we adapt and we culturally tailor things so that they are appropriate? So Betancourt et al. Explained cultural appropriateness, cultural competence as a strategy to improve quality and eliminate racial ethnic disparities in healthcare. Okay, and so of course the goal is to deliver the highest quality care to every patient regardless of race, ethnicity, culture, or language proficiency. The drive for health literacy and linguistic appropriateness. We see this most powerfully in our emergency rooms, to the extent that we become here in New York City a magnet for immigrants from all over the world. Arrive at the emergency room. Oh no. Okay, could your 7-year-old child please translate for this 65-year-old grandfather who wants to describe his prostate problems? You know, doesn't quite work very well. So to what extent do we need to follow the Association of American Medical Colleges and the way that they have sought to ensure training that produces both cultural and linguistic competence? We're going to hear from Maria Marzan tomorrow, who basically, along with myself as her sponsor, did a wonderful job, Maria did, in adapting their guidelines to create a tool that was given to medical students upon entrance and can also be given post their medical education, where they were asked to evaluate their own knowledge, skills, attitudes against all of those competencies that they identify, and also how they rate their importance for their medical school education. So you may want to hear those results from Maria tomorrow. And of course, health literacy and linguistic appropriateness are vital considerations. Because how can we deliver any health information? Indeed, a central task of all of us in this room is delivering health education. Our medical practitioners and all of those who are working in these disease prevention and health education. So that is absolutely critical. The drive to ensure the right to health. The Public Health Association, the American Public Health Association, certainly has embraced this as an absolutely critical goal, so that the discourse on the right to health is something that's been going on globally for quite a while now. And so the idea is that closely aligned with the right to health is the right to determine what constitutes health. What are the health standards, outcomes, way of life? So we have to respect and accept members of diverse cultures and their right to self-determination. And so that's an overarching principle operating here, that individuals, groups, communities can self-determine their own health outcomes, and ideally are empowered so that they can sustain that which will help them to self-determine their health. And so as evidence of this drive, we can turn to the work of Braveman again, who talks about how the foundations for addressing health disparities and pursuing health equity come not only from ethics, but also from the field of international human rights. And so we're talking about those rights or entitlements that all people in the world have, regardless of who they are or where they live. So the right to health is becoming a global fundamental concept. The drive for social justice and acknowledgement of forces in the social context. And so here, again, we see talk about the right to health and also social justice, that these are going to go hand in hand whenever we talk about equity, and that it's crucial to pay attention to the social context. The social justice piece goes hand in hand with training, because we need to inculcate in professional and personal identities a sense that one is not only a health educator, one is not only a psychologist or a nurse or a teacher, but that an additional dimension of your identity as a professional and as a community member should be a willingness to take social action for social justice. And then we also have the work of others, Diedrichson et al. The idea is that when we now talk about the social context, there are certain kinds of social context factors, those involving social stratification, those that involve differential exposure to health-damaging factories. Where do we put our incinerators, for example, in what kind of communities? What about differential exposure? Where do the diesel trucks go? How is it that we have such high rates of asthma? What environmental factors might be involved? So there can be differential vulnerabilities and susceptibility that can also follow from differential exposure. And again, the result could be unequal health outcomes and differential consequences of illness. The drive to protect and support the most vulnerable, again, we would have to have that consciousness that what affects one affects all. We would have to have that consciousness about our fundamental interdependence. We would have to, therefore, with such a consciousness, focus on those who are the most vulnerable. And they tend to be populations or groups defined by racial or ethnic status, or socioeconomic position, or age, or gender, or sexual orientation, or other perceived population or group characteristics. And we're also talking about all of those groups that tend to be negatively stereotyped and stigmatized, as well as targets of hate and violence. So there is diversity in the kind of projects that, for example, the students in the Department of Health and Behavior Studies, or those associated with the research group on disparities in health, can focus on, okay? In other words, there can be virtually any group justifiably serving as a focus, given how they may be targets of hate and violence. And so here in the United States, we would say that among our most vulnerable, particularly in recent decades, would be the incarcerated Black males in particular. But we also have global policies that create new vulnerable groups. And so these policies involve war, violence, global warming, government corruption, lack of access to essential public health or medical services, and of course the erosion of civil liberties and freedoms that occurs. And so there are many kinds of social conditions that can end up creating new vulnerable populations. So under Principle 11, we would follow a drive to protect and support the most vulnerable. And then, of course, the drive to repair damage, restore trust, and take responsibility. A great deal of damage has been done, and that includes a host of negative consequences experienced by those subject to forces of oppression. Remember that A over B paradigm, who has historically suffered. And so how do we begin to repair damage and restore trust and take responsibility? And a number of authors have addressed this theme. We will just identify a few, and damage is spelled with 2 A's. Okay, and so we turn to the work of Randall. And in terms of the work of Randall, he locates the destruction of trust in the medical and oh, this is a woman. This is a black woman. I apologize. Look at that social conditioning. Randall, he. No, Randall is a black woman. Randall locates the destruction of trust in the medical and healthcare system, as well as in medical personnel and researchers within the long history of medical experimentation in the United States on blacks, prisoners, and members of the armed forces. And so there's a deep distrust that she talks about that's literally in the consciousness of the black community, and that contributes to disparities in health because people may not seek out care, etc. In the same vein, Washington, again in her book Medical Apartheid, does the same kind of detailed history of that experimentation on blacks dating back to colonial times, surgeries that were performed on women, for example, to perfect gynecological procedures, the abuse of enslaved African Americans. And lo and behold, we might not know, but Washington documents how it continues up to the present day. There's still forced experimentation on prison inmates, soldiers in the armed forces, and the erosion of informed consent. So experimental procedures are used in emergency rooms on non-consenting victims. And so she talks about a deep-seated fear, in other words, black iatrophobia, a fear of medicine. And so Washington goes a step further in terms of her vision of medical research education. How do we restore it? She's suggesting this medical research education, which would include making accessible, to lay people, lay education that would cover medical research, assistance navigating clinical trials. We could have brochures, websites, access to experts that's made readily available. We could also have church health fairs, social organizations, community activism. So indeed, we're even going to have someone at the community health fair tomorrow who's going to be talking about a potential trial. And so the idea is that to what extent do we have organized activities that help people to navigate and to become educated about those trials? Even better, community members should actually be joining institutional review boards and asking the difficult, hard questions. And if the questions and the answers go well, to actually encourage members of diverse communities to participate in trials. And so, finally, the need for African Americans to set their own research agendas as an ultimate avenue for taking responsibility. So we would like to look at the annual Health Disparities Conference and our diverse team that came together and conceptualized this conference with people such as Dr. Ogie Degby, Dr. Fully Love, Dr. Aline, and many individuals such as Dr. Jessica Adams Skinner, who's going to be a great researcher in coming years, that this very diverse group, including Ed Gordon of the Institute for Urban and Minority Education, we envision all the components across a series of meetings. And what was at the heart of this also was the idea that this could also be a place for setting research agendas, which is why at 2006, in that particular conference, we put out the call that we did for a decade of evidence-based research to reduce health disparities. Other factors involve socioeconomic policy, the drive to redistribute wealth and access to opportunity. Who would think that so many research studies end up concluding today that not only is there a robust effect of income on health, evident in many different ways, as you can see, but the idea that those who have less income certainly tend to be more disabled, live less healthy lives, and die at younger ages. And so part of what Kawashi and I talk about is how race has been used to really divide us. And that what's really needed is a class consciousness. And if we had this kind of class consciousness, the idea is that we might have social solidarity, as you see in that third bullet there. And the bottom line is that if we can achieve that social solidarity, then we might understand why so much research that concludes that we need to redistribute income and also ensure equal access to educational and employment opportunity, that it needs to come about through something such as a movement that cuts across race lines and that allows us to experience a very broad type of solidarity across all lines. And so the idea is that if we're divided, we can fail to see our common interests. Instead, there are values that brave men identify, such as distributive justice. Distributive justice as the equitable allocation of resources in a society. And so there is a drive to redistribute wealth and access to opportunity. So as we move toward our conclusion of this particular opening address, what is it that we need? I would say that we need to move from an equity in health to equity in health, and to shift our discourse and talk more and more about what we want, which is equity in health, to launch this new field of equity in health, not only through the volume that Springer has published, but also in the online journal. Why an online journal? Because it represents the equitable access that we're talking about. That one need not purchase a subscription to an expensive journal, for example, and then ultimately a 21st century global civil rights movement for equity and health for all. And so today, we declare a 21st century global civil rights movement for equity and health for all, and I invite all to repeat with me the next two bullets. Are you ready? I am calling for a 21st century global civil rights movement for equity and health for all. Okay, we gotta do better than that. We're gonna say it 2 more times. Ready? Here we go. I am calling for a 21st century global civil rights movement for equity and health for all. One more time. I am calling for a 21st century global civil rights movement for equity and health for all. And we'll only say once. I am committed to taking action to ensure the right to health. And so now, this is an affirmation for you. What does commitment mean? It means I am who I say I am. I do what I say I'm going to do. If I ever fail to be or do what I said I would, I apologize and recommit, because we're human. And in this human condition, we tend sometimes to make mistakes. And so what's needed then? Forgiveness, apology. So we again go to Ayawafo's book, Tigray Speaks. Not only that value that what affects one affects all, but the value of interdependence, apology, pardoning, forgiveness. You see, you can pardon someone, and that's a little bit less emotional, okay? But to forgive, a little bit more emotional, but to apologize. And so this is some of the values coming from the African healing wisdom that can guide us. And so that's the book. Apology, pardon, forgiveness, interdependence. And so what am I now thanking you for? I thank you for your commitment, for welcoming and mentoring the youth who are going to be here, particularly tomorrow, from college, from Kingsville College, other places, because we need to create a pipeline. I thank you for welcoming our community members and to foster that healing with our community members who are our guests, so that we can develop community partnerships based on mutual respect and recognition. And I thank you for your presence at all of our events today and tomorrow. Let's give ourselves a hand. Thank you. Okay, put up this PowerPoint, Sonali. And so now we're going to have Professor Doug Greer, who is, whose bio is in your book, and you can Google his name and read everything if you have a few hours. But I would just like to say that even as Teachers College searches for models, because Teachers College would like to have a school. And you know, they can travel to Philadelphia, they can travel all over the nation and look for viable models. But I tell you that in the work of Professor Greer, we have something that could make our homepage motto, education, no, equity, whatever it is, educate. What does our homepage say? Who wants to get extra credit? Okay. Any event.
The preceding program was brought to you by Teachers College, Columbia University. Please visit us online at itunes.tc.columbia.edu.